All right, you guys. So I'm going to go ahead and jump into looking at CVAs and strokes, our acute brain attacks, and we'll go and build on some more neuro stuff later. But when we're talking about stroke or the term acute brain attack or CVA, what we're talking about is a sudden loss of brain function due to either oxygen not getting to brain tissue or the circulation of the blood flow has been stopped or paused or minimized in some way. So the concern is that the brain tissue is not getting the oxygenation that it needs so that it can be nice and healthy and help us work and function. So some of our causes or reasons we can have a CVA, as well as different types, are either a transient ischemic attack or a CVA, which is a cerebral vascular accident. So when we're looking at a TIA, it just means that it was a brief period of time where oxygenated blood flow was able to get through to tissue in the brain. So if we may have had a vessel that may have had some plaque buildup or something in it that prevented a good amount of blood flow, oxygenated blood flow, to get to the brain. So as a result of that, patients ended up with a transient ischemic attack, a shorter amount of oxygenated blood flow that got to the brain. The other one that we commonly hear about is the CVA, cerebral vascular attack. Now that has a couple of different causes that go under it. So you can have an ischemic attack or a thrombolytic or an embolytic attack. So with the ischemic attack, what we're saying is that there is no blood flow that was able, oxygenated blood flow that was able to get to the brain and feed it oxygenated blood flow at some area in the brain. Because the blood flow was stopped or paused or could not go forward, we have ischemia. Okay, so that just means that blood flow didn't get there. Oxygenated blood flow didn't get there. If it is a thrombolytic or embolytic vascular accident, then that means a clot has gotten there and actually has wedged in the vessel and has prevented blood flow from going past a certain point. The next type of CVA that we have is a hemorrhagic. So hemorrhagics can be brought on by cerebral aneurysms. It can be brought on by elevated blood pressure like hypertension. It can be brought on by bleeds or if overuse of anticoagulants, things like that. So we're concerned that the vessels in the brain have ruptured, leaked in some way, and because they've done so, it has released blood into the area of the brain where the brain is or in the brain, and thus it causes pressure to build up in there because we don't expect for blood to be in certain areas. So as a result, we have increased amount of intracranial pressure, which causes problems for our patients. So transient ischemic attack, a CVA, or a CVA, right? Cerebral vascular attack. And of the CVAs, we have embolytic, thrombolytic, or thrombotic, and ischemic. And then the last one that we talked about was a hemorrhagic. Hemorrhagic is when we have a bleed in the brain that increased intracranial pressure, and our patients present with a massive headache. They'll say that it's the worst headache of their life. It'll be sudden, it'll be fast. So we're going to be worried about those things. So some of our risk factors, all right? So we went through what is a CVA. We then went through the causes of some of the attacks or the different types of attacks. And so now we're going to talk about some risk factors. What is my patient that would be at a greater risk for developing a CVA or developing some type of brain attack, stroke, whatever you want to go with, whichever term? So hypertension is one of our biggest ones, right? And when we're looking at hypertension, we're looking at a systolic number that is greater than 140. Okay, so a systolic number greater than 140. And we know that with hypertension, it puts extra pressure on the vessels as the blood flow is pumping through there. And so that can increase a patient's risk for developing a stroke. Next is smoking. I won't say next because it's not really priority order, but smoking does increase the patient's risk for developing a CVA or having a stroke, and that's because smoking does damage and weaken the vessels over time, so therefore it has a harder time getting blood flow around. When it comes to diabetes, our diabetic patients are at a greater risk for it. Our ladies who are on oral contraceptives, they have an increased risk of having CVAs just for the risk of taking an oral contraceptive. Substance abuse, patients who have a history of substance abuse, obesity. Of course, we know that the extra weight will increase our risk of putting pressure on those vessels to move things around. Certain coagulation disorders like sickle cell, things that causes our blood to coagulate very easily. One other one may be like a valve malformation, or a patient had a history of AFib. Those are all things that could be like coagulation disorders. The use of anticoagulants, which we talked about, and hyperlipidemia. So that's that increase in lipids that could easily kind of build up and make it slower for blood flow to get to an area in the brain. So all of those are some of the reasons that could cause a patient to have a CVA. So when we are looking at a patient who may present to us, or we've been caring for this patient for a couple of days, and we come in, what are the things that may put us in the realm of this patient may be having a stroke? So we're going to be looking at the signs and symptoms next. So if your person suddenly has an elevated blood pressure and the blood pressure has a systolic of 140 or greater, right? That's going to key us in or put us on alert. If they have a headache, again, we're looking for a sudden massive pain headache. If they have nausea and vomiting, right, that's kind of sudden as well. Unilateral one-sided hemiparesis, right? So not able to move or having a weakness in one side of their body, or a paralysis in one side of their body. And that may be a facial droop. It may be an arm not being able to lift. It kind of sways back when we do that arm assessment, when we're having that neuro check, when we're having them push, pull, squeeze with their hands. It could be on the face, arm, or leg. Right, so we're looking at one half of the body being affected by the stroke. As a result of that hemiparesis or hemiparalysis, our patient can also present with sensory deficits, right? So they may neglect this side of the body. If the paralysis is on one side of the body, they may neglect that side. They may not remember to look to that side, or they may have some visual deficits on that side that's affected with the hemiparesis or hemiparalysis. Their muscle movements, they can be flaccid, right, just really loose, flaccid, or they can be rigid, kind of stiff or very toned. With those things that we're looking at, those all help clue us in that something's different. Patient may be experiencing a stroke. Other things that come with it would be aphasia, and that's just difference or issue with verbal communication. So either expressive, being able to get the right words out, or receptive, they're not able to understand easily what we're saying. So it could be a type of aphasia. Agnosia is another one, which is like inappropriate use of an object. So if they're not using the object in the right way, you know, something weird, like trying to use an eating utensil for a hammer, something of that nature. So anoxia is another one, and that's AGNOSIA. Okay. Dysarthria, and that is the inability to be able to articulate your words, right, and get them out. So speaking as well. Apraxia is inability to have purposeful movement and being able to control those movements. So again, that's looking at kind of that arm drift and things like that. We are going to also look at assessment skills, such as your cranial nerves. Your cranial nerves are going to be one, especially because we have those visual deficits that may play into a factor. So oftentimes we're still going to be looking at those 12 cranial nerves and testing those when we do some of those neuro assessments and checks. Another term to look out for that we don't really hear it a lot, and so it throws people off, throws some students off, is hemianopsia, right? So that means they are blind to one side, right? They're not paying attention to half of their visual field. With those patients that we are suspecting are having a possible stroke, we need to act fast. I know everyone's seen that little, it's not little, it's a poster, right? Everybody's seen that poster that is out there that says to act fast. Your F stands for recognizing if there's a change in their face. So is there a change in their smile? Is it a change in how they're holding their lips, how their eyes look? Right? Is there some type of droop on one side? Arm drift, again, so if they're not able to hold those arms right in front of you and be able to keep both of them up, or does one arm kind of sway and fall down? Speech impairment, so that's our S. And then time. The time is vital for these patients if we are suspecting that they are having a stroke. We want to get them to medical attention if they're already in the hospital and we're providing medical attention. We want to get them down to CT as soon as possible so that we can kind of confirm where it is and what's going on in the brain. So those are some of the things that we're going to be looking for, especially if we suspect that they are having a stroke. All right. So those are all the things that our patient may present with, right? May have headache, may have a history of hypertension, or either they have an elevated blood pressure, unilateral weakness, not able to move appropriately as far as walking, or ataxia without being able to walk appropriately, things of that nature. What we are going to do next, or expect to happen next, is that the physician or healthcare provider is going to do or order certain tests to confirm the suspicion of a stroke. So we have to have certain diagnostic tests to help us do that. So we will, of course, do our patient history, do their physical, definite looks into the neuro assessment part of the physical, right? We're going to expect that an MRI may be ordered, a CT may be ordered, or a CAT scan, right? Sometimes it just depends on doctor's preferences, how our patient is, what the history is, for them to decide. But one of those three are probably going to come into the play real soon. All right. One of the reasons why we need to know for sure if it is a stroke and what kind of stroke it is because the type of stroke can depend or determine rather the type of treatment plan we do. So if we have an ischemic stroke, it's going to be different, the treatment plan that we'll have for them, versus if we have a hemorrhagic stroke. Okay, and we'll talk about that in a little bit when we kind of get down to meds. So things that I want to do for my patient once it's been confirmed that they have a stroke, or even if I'm suspecting they have a stroke and I'm waiting to get down to CT, right? I want to manage or watch for signs of increased intracranial pressure. We want to make sure that their headache isn't getting any worse, that they're not having any what we call diplopia or blurred vision. They're not having increased vomiting, things of that nature. We're going to monitor bowel and bladder function. They will probably be NPO until we see fit to change that. And the reason being is that these patients can have issues swallowing, and we don't want to compromise that airway, right? So airways are going to be big concern with these patients because they do have difficulty swallowing. So we're going to be looking out for that. And then, of course, listening out for breath sounds as well. So those are going to be big key things that we're looking at for nursing management. Nursing activities that we're going to be doing while we're caring for this patient. We want to make sure that we are maintaining that airway, right? We have to keep O2 going to that going to the lungs so that it can get to the brain, right? So we want to maintain a patent airway. We may put them on seizure precautions, and we may actually ask them to do bed rest. And reason for that is that we want them to decrease the risk of increased intracranial pressure. Right? So if we're up and moving around, or if we have increased sensory in the room, TV's on and it's blaring, things like that, we're going to increase a person's intracranial pressure. So we want them to lay down, calm environment, decrease stimuli, and possibly put them on seizure precautions, right? Which is low bed, pads on the rails, door open near the nurse's station, that type deal. We want to assist them with their ADLs, and I want to be mindful that when we're doing assisting of ADLs, we are assisting these patients who have stroke, is that we want them to remember the side that may be affected, and they may not they may have some neglect on that side. So we want them to be as independent as possible and learn their new way of life, especially if they have residual effects from the stroke. Complications. So if my patient has a stroke, has a CVA, a brain attack, what are some complications that can happen long term with my patient? We could have impaired verbal communication, which we talked about, that was aphasia, right? So we can have impaired expressive, meaning that your patient's not able to get out effectively what they want. They get frustrated when they talk. So what happens is that they may have to communicate in short phrases. These patients completely understand what we're saying to them. They just can't get their response out as quickly as they would like to, or as effectively as they would like to. Or they can have an aphasia with the poor verbal communication that is receptive, meaning that they're not able to understand what we're saying. They can speak fine, but they're not able to understand what we're saying. And so with those kinds of patients, we want to treat them differently, right? So with expressive aphasia, we want to give them plenty of time to answer, give them a lot of patience, right? Because they're going to be a little antsy and may have some frustration with getting words out. With receptive aphasia patients, we're going to be more concerned with helping them understand what we want them to do. So that may be short phrases. It may be that we give to them. It may be using a picture board, having them point at something, and just kind of minimizing the way that we're communicating with them, so that it takes some of the pressure off with them trying to process and understand. Other complications, sensory perception deficits. So they may forget about that other side. So if they forget about that other side, they may end up walking into a wall, right? Let me just put something that's like very, very far out there. They may not be able or remember to clear like a doorway before they walk through because of that hemianopsia, right? Because they see one side, or that one side is not present to their visual field. So sensory perception deficits. Being able to feel sharp versus dull, different types of touches, hot versus cold, those types of things. They may have constipation or urinary incontinence. Contractures are extremity deformities. So if we're not doing appropriate kind of range of motion on them, things of that nature, it could lead into a longer term issue for our patients. Okay. When we are looking at special populations, we of course have to address the aged or elderly population. Our aged population is at a greater risk of developing strokes, only because of some comorbidities, possible diabetes, possible history of hypertension, and then if they have a stroke, we're going to be concerned that they're at an increased risk of falls. We're going to be worried about their mobility. We're also going to be worried about nutrition. Because they have impaired swallowing, they may not be eating like they should, so therefore they're not getting the nutrients that they need to get. So with our special population, we're going to be looking at nutrition and mobility practices with them after they've had stroke. All right. So that's kind of the big picture of it. We talked about putting them on, if we're caring for the patient with a seizure, with a stroke, we're going to be possibly looking at putting them on seizure precautions, frequent neuro checks, and that may be like every 4 hours. They may be ordered to, you may have an order to do neuro checks. The other thing I did not talk about when we were looking at kind of the management activities type deal for nursing is that we want to cluster care, meaning that we want to put as much together as possible so that we can give them moments of rest and moments to kind of like reset. So when we do that cluster care, that means we may go in and do medicine, assist with ADLs, right? If I'm not able to stay in for the full time as the nurse with ADLs, I may see if my care partner can come in, or my CNA can come in to help me get those done, right? So hey, I'm gonna go in for meds. Let's couple doing the bed change and linen change, as well as giving the patient's bath at that time, so that we can kind of get that care together and we're not overstimulating the patient. We want to possibly think about therapy too when we're looking at clustering care, or how we're going to give therapy. When I'm saying that is that if you're in a situation where it's a team environment, right, and a lot of interdisciplinary teams are working together, you might want to schedule with PT, OT, or speech, right? Who's going to come in at what times to help and make sure that the patient's not overstimulated. All right. Transferring, right? If you're going to transfer your patient, you want to transfer them toward their stronger side. So if I'm getting the patient up and I'm going to get them from the bed to the chair, I'm going to want to put the chair on the patient's strong side. So that way when we're standing up and pivot, or we're going towards that patient's strong side versus the side that they may not remember is over there. Okay. So you're going to go or transfer them towards their strong side. It's pretty much the biggest things. So let's get into talking about meds. Right? Fun, pharmacology. Right? So when it comes to meds, again, it depends on what type of stroke your patient had. Did they have an ischemic stroke, a thrombolytic, embolytic stroke, or did they have a hemorrhagic stroke? If your patient had a hemorrhagic stroke, they should not be given an anticoagulant, an antiplatelet, or antithrombolytic. Okay? All three of those will increase their risk of bleeding, right, and make the situation worse, increase intracranial pressure, and that's no fun, right? So anytime we have a patient that we suspect is having a cerebral hemorrhage, we need to get it verified with MRI as to whether or not they're still actively bleeding, or if it is a bleed, and we cannot give them any of those things that will increase their risk of bleeding. So anticoagulants could include warfarin, Coumadin, Lovenox or enoxaparin, heparin. I'm trying to think of some ones that you may see in clinical a lot. Any of those medicines, we cannot give them. Antiplatelet medications. Most of the time we automatically go to the prescription meds like clopidogrel, Plavix, but also think about your aspirin, your over-the-counter medications, especially for some of your patients. We said the patient who has AFib may be at risk for developing a stroke, right? So in their daily regimen, they may have aspirin that's on their daily regimen, right? So we would have to hold that aspirin and make sure we communicate with the doctor on our orders to see when we want to start back giving them that aspirin, or what's the next type of treatment we're going to do for that patient. Next is antithrombolytics. Again, these are medicines we would not give a hemorrhaging cerebral patient, right, or a hemorrhaging patient, period. With our thrombolytics, right, those end in ACE, so ASE, so streptokinase. There's like one more that's big, but I can't think of it right now, but they end in ACE. We are not going to give them those medications. And the point of a thrombolytic is that it actually goes to break up the clot. The other term that you may hear is a TPA. And the TPA just stands for tissue plasminogen activator. So it activates plasma being able to get through and get to the tissues. If we had a patient who had an ischemic stroke, our thrombolytic, our embolytic, all of those medicines, class of medications that we just talked about, would potentially be appropriate to give to our patient. I bring that up because with our thrombolytics, we have a specific window of time for them. We have up to 4.5 hours, 4.5 hours in order to administer this medication. So that's why when we're looking at FAST, which is where it came from, the FAST, the facial smile droop, the arm drift, speech impairment, and the time sensitivity, we are looking at that because that is one of the things that families, is easy for them to pick up on, and they can say, hey, something's seeming off about you. I think because of, I know the acronym FAST, you may be having a stroke, so let me get you to the doctor immediately. And with that said, they can say, this probably started like an hour ago. If we do the MRI and figure out that it is an ischemic stroke or some type of clot, that patient would be appropriate to give a thrombolytic to. Okay. Other medicines that we may consider giving patients after they've had a stroke: anticonvulsants, right? We have them on seizure precautions because of the risk of increased intracranial pressure, right? So we don't want them to have a seizure. We don't want them to have increased intracranial pressure. So anticonvulsants may be on the list of medicines to give. We may give them stool softeners, and that's because we don't want them to strain and put pressure on the inside of their body, which could increase pressure and have them bear down. And then lastly, which we're going to talk about a little bit, are antihypertensives, right? So we are going to give them medicines, especially if they have an elevated blood pressure at the time of admission or being brought to the hospital, what have you. We are going to give them antihypertensive medicines. So if we give them antihypertensive medicines, the goal is to lower their blood pressure. Again, we said that a blood pressure above 140 is something we need to pay strict attention to. With that being said, if they have a blood pressure that's in the 200s systolically, right? If that systolic number, that top number, is up in the 200s, we are going to give them IV, right, antihypertensive medicines, and we're going to be kind of monitoring their lowering of blood pressure. The reason being is that when they're at 200 or higher, we don't want to quickly drop them down to 140 or lower. We need to ease them down. So for the first 24, 48 hours, right, depending on the doctor and what they order, if they're above 200 or at 200, we're going to try to slowly lower them down, but not take them past 170. So if it's above 200, between 200 and 170 is where we're going to keep them for the first 24 to 48 hours, and then we'll drop and lower it some more. so we can get them back into either their baseline or into what we want them really to be at for a new baseline. We don't want them to drop too quickly and crash that blood pressure out, right? Especially if we're looking at giving IV medications, because those IV medications, again, they go in intravascularly, so they go in super fast. They have a quicker effect on your patient, right? So that's just a little note about blood pressure medicines. And I think that's about it. That's pretty much all I got for you for strokes and CVAs. We did talk one more thing. We did talk a little bit about some of our interventions. Make sure that when it comes to, I did say that they may have some trouble swallowing. They're going to be NPO until they are cleared by with a swallow screen, right? With that being said, they oftentimes, when I say they, these patients who have difficulty swallowing, oftentimes are going to have diet orders that include like pureed or soft or give with thickened liquids. They cannot just have plain like liquids or food that may require a lot of chewing. So until they are cleared, they are NPO. After they've had that swallow screen, they may have an altered diet order in order for them to be able to have their meal. So watch those meal trays and look at those doctor's orders for their diets. Tips that you may see with people when you're trying to get them to eat is keeping the head of bed up, right? Because we're going to encourage them to sit up so that they can swallow. No meds that could be sedative before we get ready to feed them, right? We need them as alert and perky and happy to go as possible so that they can concentrate on chewing that food and swallowing it. And then eating, lastly, would be flexing the neck. And so sometimes that is getting them to put their chin to their chest and go down when they get ready to swallow. So they can chew when they're ready to swallow, bend their head down and swallow, right? So that's what we're looking at there. Be mindful of your directions, right? So flexion versus extension, things of that nature. When we're flexing, we are pulling it towards and making that area right there contract. Okay, I think that's all I got for you. We'll keep going with some neuro stuff in a couple more videos, but I'll get back to you shortly, and I'll see you until then.